Hello, this is your Brain on Drugs and Punk Ruckus Psychiatrist. So today, I'm going to be talking about the future of treatment of depression. You know, we've gone through the history of the treatment of depression from medications used before MAOIs that aren't used anymore because they were kind of all we had. I think people use things like amphetamines and opiates and stuff that was available back, before the 1960s. And then we had the MAOIs, and then we had the TCAs coming on around the same time. And then, we had the theory of monoamines as the solution to depression, and the desire to make medications that were having all the positive qualities of MAOIs and TCAs without the negative side effects. And so the selective serotonin reuptake inhibitors and SNRIs and these more selective medications came out that didn't have like the anticholinergic effects and all these type of effects. But we've been going on with this narrative of monoamines. And while they're at play, I think, at the present, the theory of depression is less tied to this monoamine theory, that it's not the root of the depression. It's maybe not the way to fix it for a lot of people, if not majority of people. But it's the only treatments that we've had until recently. We've had some of the few medications that don't use this method, meaning the NMDA receptor antagonists. But these are not perfect solutions either. But so I think there's this search for what's next, what possibly could come out and do a better job than what we've had before. Maybe have less side effects that are bothersome, be better targeted, more effective. In other disease states, in medical illnesses, we have treatments that are so much more effective than we do for mental illness. And inside mental illness, I see depression as probably what's the worst. It's what we're doing the worst job at. Antipsychotics do a fair job against schizophrenia and psychotic disorders. The mood stabilizers do a pretty fair job on bipolar disorder. The stimulants do a fair job, a pretty decent job actually, on ADHD. And although the benzodiazepines may have a lot of drawbacks with dependence and tolerance and things, they actually do treat anxiety fairly well. We don't really have something equivalent to these drugs when it comes to depression. And depression is one of the most common problems in mental illness. We just don't have great treatments for it. And this is one reason why I'm doing this podcast, and this is one reason why I'm doing antidepressants first. To me, they're the biggest disappointment. Not that, I blame scientists for not coming up with a solution. I think depression is such a complicated disease state. It's just so complicated. And, I think we have a much better understanding of what's going on with bipolar illness or with psychotic illnesses. And we have better ideas on like how to actually go into the brain and chemically interact to fix those. With depression, I've recently heard some interesting theories. Depression and bipolar disorder used to be combined into kind of a continuum of this bipolar manic disorder. The manic depressive disorder, where you had a spectrum of maybe mostly depressed or mostly manic or somewhere in between. And at some point, these two disease states were paired off and separated into bipolar illness and major depressive illness. And I think in that we've taken what might be some folks that are in this depression sphere, maybe they do fall in side of this more disease state, manic depressive state that is more responsive to medications that we have. Maybe medications we use for bipolar disorder, such as carbamazepine and lithium and divalproic acid and things like that, um, and maybe less responsive to some of the more traditional treatments that I've been discussing up till this point, right? And maybe a lot of the other folks that, meet the DSM kind of qualitative, man-made criteria for what we're saying depression is, um, maybe that's more of a psychological issue, something that's not so much responsive to medication. It's a much more complicated disease state that medications, it's a very simple tool to handle a very complicated issue. And so maybe there's a subset of those that are within this MDD sphere that maybe would respond better to bipolar treatments or antipsychotic treatments or even some of our antidepressant treatments. But a lot of folks maybe are different, while they meet the same criteria, it's a different disease state, and they just don't respond well to the medications, right? So I think this is an interesting kind of philosophical thought, and it's something I'll probably talk about more in the future. But I think that's why the antidepressants, they are so underwhelming as far as compared to our other treatments for mental illness, is because I'm not sure that we really know what depression is in a real chemical, physical form. There's so many different presentations, and we have vague ideas, and we can look at brain scans and see sort of patterns and things like that. But a lot of people also admit, these medications are supposedly only good for severe depression, and perhaps it's severe depression that's the actual disease state of depression, and the mild to moderate symptoms, maybe that's not depression. Maybe that's something akin to depression, but it's a separate illness. You have the same symptoms to a lesser extent, but it's not the same illness. And I don't think we really have a good idea what that is. I mean, when you look at the DSM shows us it's just kind of, it evolves. Look at the DSM 1, 2, 3, 4, 5 and all the iterations. They change what suits each disease state from manual to manual. And they even rename disease states. They remove diseases. They add diseases in. And this is not the way it works. Whatever's going on has been around for thousands of years. It's not something that is evolving and changing over the last 50 years that we've been writing these manuals. The honest truth is that we don't really know. And we're doing our best to try and combat these things. And that's why I talk a lot about when we're talking about the treatment of depression. I like to use, I mean, I think medications add an amazing placebo effect. I think they do help some folks more than others. And maybe we don't know which folks those are. I think um, the placebo effect that goes along with them is very powerful. I think the doctor-patient relationship is very powerful, and how you harness that and how you talk about the meds and how you relate to the patient is probably more important than, and a lot more important than the actually how the meds are chemically working in the body. Okay. And I think if you keep that in mind, you're going to do better for patients. So right, this is the disease state that we are the least effective towards. And maybe it's because we're not categorizing it correctly, we're not understanding it correctly. We don't know who fits into what box, but it could also be that maybe we haven't come up with the right tool. So, on the horizon, and what I'm going to talk about in this episode, are a host of other medications that are coming out that use a variety of different mechanisms of action than anything that we've seen thus far. Now, so far, some of these meds are not looking like they're going to be that promising. Others, we don't know yet. Okay, so let's go ahead and um, step through them and see what we've got coming out. All right, so here's a list of all the medication categories that I'm going to talk about. First, we've got neurosteroids. Medications like brexanolone and zuranolone fall into that category. Then we've got medications that interact with the glutamate system. Now, we've already talked about ketamine, esketamine, um, dextromethorphan, bupropion, but we've got some other ones coming out, such as hydroxyketamine. We'll talk about, there's a few more. Then we've got the 5-HT2A agonists. All right, so these are psychedelics like psilocybin, LSD, MDMA. Um, then we've got an interesting category called the cestrin modulators that interact with mTOR. We've got BDNF modulators. I've talked about BDNF is something that helps with neuronal growth and connections in the brain. And so we've got some medications that are trying to harness that to a higher degree. There's a medication out there that it works as an H3 inverse agonist that I'm going to discuss. There's a melatonin 1-2 agonist that I'm going to talk about. Then there's the TrkB system. That's capital T, little r, little k, big B. And this is something that's also involved in BDNF. There's a medication. There's several medications that already interact with this system, but there's a new one coming out that does it a little differently. Then there's the kappa opioid receptor antagonist, buprenorphine. That there's some interest in that for treatment for depression. I'm going to discuss that. So I'm going to talk about medications that are in the pipeline, in development, in phase 2 and 3 trials in all of these categories. And then there's two more that I don't have any examples of, but there's some research going on about. So there's the histone deacetylase inhibitors, and valproic acid is actually in that category. Now, unfortunately, it's been coming out. We've known that this is not safe for women who may get pregnant, and we're now finding out that it's not safe for men that may be providing their genetic material to produce new life. That this can actually affect that and then affect the baby as well. And so I'm not sure that there's going to be any treatments using the histone deacetylase inhibition process in depression. And valproic acid, which uses that, is the only medication I know of that is one of those inhibitors, is falling out of favor more and more and more because of that. Another one is fatty acid amide hydroxylase inhibitors. So FAAH actually breaks down anandamide, which is the endogenous cannabinoid that we have in our bodies. All right, so that cannabinoid, we're talking about THC, we're talking about cannabis, marijuana, um, ways of harnessing that system without using the mind altering substances. So there's research going into that mechanism. Um, so we would be increasing our amounts of the anandamide, so increasing the amounts of the naturally occurring cannabinoid that we have in our bodies without taking external substances. So there's some research on that, but like I said, for those last two categories, there are no meds in the pipeline yet that I could discover. But for the other ones, we do. And so let's go ahead and discuss those. First one is the neurosteroids. So these are, as I mentioned, brexanolone and zuranolone are examples, and these are meds that have come out in the last few years. I'm going to discuss them later when I talk about postpartum depression. But these meds are based on a system originating with we've got pregnenolone. It's a precursor of allopregnanolone, and it's actually available over the counter through some herbalists, might be prescribed by alternative medicine practitioners, right? So pregnenolone has been out there. Not sure that it's really all that helpful, but it is a precursor to allopregnanolone. Now, pregnenolone levels fall postpartum, and this is thought to contribute to depression. So brexanolone and zuranolone kind of came out as synthetic allopregnanolone. And this allopregnanolone, it affects the GABA A receptors. Now we haven't talked about GABA yet. It's what the benzodiazepines what they interact with. When we talk about the anxiolytics, we will get into GABA. Alcohol interacts with GABA. So that these also interact with the GABA A. There's a GABA A and a GABA B. So GABA A receptors. But these are the GABA A receptors that are not sensitive to benzodiazepines. So they're binding at different points. They act as positive allosteric modulators of GABA A. At low dose and high doses, They stimulate GABA A. At medium doses, they inhibit GABA A. These same levels are seen during the luteal phase, so that is a phase within the menstrual cycle. And they, unlike their, cousins, the benzodiazepines or barbiturates, they're not known to be habit forming. All right, so we already have these approved for postpartum depression. It's possible that medications like these or other neurosteroids that work in the same way might come out in the future for treating not just postpartum depression, but regular depression. And I think that there's, when I talk about these medications, I'll mention some of the other conditions that these medications are being tested on. So you may see these medications coming out for depression, working through this GABA A system in a different way than benzodiazepines. And so that may give us another avenue for treating depression. And I've gone over kind of the NMDA glutamate system. We talked about the three medications in a couple episodes ago. There are a couple other medications coming out, or you may or may not make it out. First is a medication, and whenever meds are in the discovery phase, often they haven't been given a name yet, and they're given a two, 3 letters indicating the drug company that's producing them, followed by a dash, followed by a number that is assigned of, I don't know if it's like an order of how they've been coming out, or what, how that number comes out. But this is REL 1017. And what it is it's S-methadone, otherwise known as dextromethadone, otherwise known as S or positive methadone. So this is an enantiomer of methadone. It antagonizes the NMDA receptor. And as you'll remember, methadone is the treatment for opiate addiction. It interacts at opioid receptors. However, the S enantiomer or dextro enantiomer, remember when we talked about enantiomers, sometimes the system we use, whether it's S or R or dextro or levo, it has to do with its orientation and whether it's geometrically, or how it spins in a certain way when light is put through it, and those sort of things. So this type of methadone, this S methadone, is actually 20 times lower affinity for opioid receptors than levomethadone, and levomethadone is the one that we're using for the addiction of opiates. So this is not an addictive substance. This is not something that's really affecting those opioid receptors. 20 times less affinity. That's a pretty strong amount less. All right. So it's mainly antagonizing NMDA receptors. Now, we get a low risk of respiratory depression and a low risk of abuse. All right. So this is really a different type of med. Even though it is, methadone, it is a different type, different enantiomer that has a completely different mechanism of action. Now, phase 2 trials showed rapid antidepressant effects. However, phase 3 trials, which were just kind of coming out in December of 2024, that's just a couple months ago as of the recording of this episode, they were very disappointing. And it's unclear if the drug company is going to be moving forward with this medication. And if so, how are they going to switch directions? So this was something that, I've had this in my slides for a while, but this trial just came out a couple months ago. I may have to delete it at some point. This may be something that's abandoned. All right. Next medication in the glutamate section is a medication known as 2R6R hydroxynorketamine, or RRHNK. All right. This is metabolite of ketamine. It activates the AMPA glutamate ion channel with downstream effects, increasing BDNF and mTOR. It does not bind the NMDA glutamate receptor as ketamine does. Okay. And it's been demonstrated to show rapid antidepressant activity in animal models. So not in humans. We don't have any proof that it's going to work in humans yet. It's only had phase 1 trial. Phase 1 trial just last year in 2024 demonstrated a lack of dissociation and abusive potential. So far we just kind of had this signal that it's not going to have the same ill effects that ketamine does, and it appears to be working in animals. So they're going to be moving forward with phase 2 and 3 trials. It'll probably be several years before we could possibly have this medication in a form that's available. But it's another and as I said, this is not an NMDA receptor antagonist, but it activates AMPA, and AMPA also it also interacts at similar receptors, and it's related to the NMDA antagonist ketamine. So another one to kind of be thinking about: 2R, 6R hydroxynorketamine, okay, or just hydroxynorketamine. All right, and then I have a third one in the glutamate category. We've got a drug known as Alto 202. This is by the drug company Alto Neuro something or other, Alto 202. So this is a glue N2B subunit containing NMDA receptor negative allosteric modulator. You're probably thinking, what the hell is this guy talking about, right? But this is a basically sort of ish NMDA receptor antagonist, but it's a specific subunit on the NMDA, so it works differently than the other NMDA antagonists. And it's not actually an antagonist; it's a negative allosteric modulator. That's not that's something that changes changes the form so that it's more or less able to do its function. It's a little bit different. It's than a straight antagonist, but it has somewhat similar results. So this does work differently than the other ones we have, and what we've had so far is phase 2 top line results are expected this year in 2025. So don't know, is this going to be effective or not? Not sure. So our first one, REL 1017, our S methadone, not looking good. The hydroxynorketamine, very early stages. We don't know yet. And Alto 202, phase 2 top line results expected this year. Now, I see phase 2 results often come back. And these are more safety. Phase 2 is more geared towards safety than it is effectiveness, and so we'll be looking forward to that, and then we'll need the phase 3 trials as well. Okay, so those are the medications on the horizon that might be following up on esketamine and Auvelity, but remains to be seen. Our next category. This is one. I've heard a lot of interest on this one. 5-HT2A agonist. Now, I'm sure a lot of folks could probably do 2 or 3 full episodes on this. I'm not, I'm dealing more with the chemistry and what's out there and things. I'm fine to just cover this on a single slide. All right. So this is something that's exciting a lot of people, that these are Schedule 1 substances. All right. So Schedule 1 is no medical use, but they're trying to, get a medical use, obviously. So doing research with these is very difficult because, when something is Schedule 1, you can't prescribe it. So it takes a lot to be able to do that research. These are being researched in, everyone's probably heard of psychedelic assisted therapy. Okay, this is what we're talking about, using psychedelic medications, which are 5-HT2A agonists, serotonin 2A agonism, with therapy to see if there's improvement. So, the patient takes the psychedelic, they have kind of this psychedelic trance state going on in their mind, and they're receiving therapy. There's 2 therapists in the room, a male and a female. You probably heard of this if you're following medications and you're listening to this podcast, or maybe you're a patient that wants some treatments. You probably heard of this as something potentially you could have. It's limited availability because it's not approved yet. And it's very intensive, so there's not a lot of space to let people in yet, into these trials and so forth. But there are centers opening up all around the U.S., UK, Australia. I said Johns Hopkins does a lot of this. Harvard is opening something. So a lot of the really big, big names in medical schools are looking into this. So there is a lot of interest. And I actually read, I don't know if this is true or not, but I actually read that that over 50% of psychiatrists have reported an interest in incorporating this into their practice. That, to me, that's a big freaking number. Over 50%. I know that I am not interested in incorporating this into my practice. It just looks very cumbersome. The fact that we have to be doing therapy at the same time, we have to have the male and the female therapist, and we're giving the med, and it's not just as simple as I see a patient, I write a script, they pick it up at the store, and they fill it and they take it. I mean, they're taking it in the office, they're having the experience while they're getting the therapy. It seems quite cumbersome to me. It's surprising to me that more than 50% of my colleagues would intend to use this. I would not be interested myself. It's, I don't know, just not something I'm all that interested in doing. I am interested in, is this effective or not? But I like the quick and dirty. That's why, I like the meds, the chemistry of them. I want to just, interact, get a sense, give someone a med. I just do it the traditional way. I guess that's my thing. But we've got three psychedelics that are being looked at here. First, psilocybin. So psilocybin was actually recently legalized for use in this in Australia. So Australia is doing this now. Psilocybin, that's the chemical that's in magic mushrooms, okay, shrooms. Um, Several cities in the US have actually decriminalized it. It's been legalized. So decriminalized and legalized are different. Decriminalized means that um, it's illegal, but there's no punishment. So basically, like, you're not allowed to do it, but if you're caught with it, you won't go to jail, kind of thing, or maybe you have to have a larger amount. But legal means that, like, this can be like prescribed and sold, and right, because decriminalized, you're not actually not legal to. It's not legal to sell it, but it's not illegal to possess it. Whereas legal is you can actually sell it. Now, keep in mind, this is kind of like marijuana and cannabis, THC. That the federal government, these are illegal. But some states have gone out on their own to say, we don't care, we're going to legalize it anyway. And the federal government is kind of like not taking the time to enforce the states to do that, right? So that half the states are allowing marijuana, but the US is still saying you can't do it, right? So this is the psilocybin mushrooms, the substance in mushrooms has actually been legalized in Oregon and Colorado. And interestingly, Colorado in the last couple of years has actually legalized DMT. Now, that's the substance in ayahuasca, the psychedelic substance used in Peru in the Amazon rainforest. Um, Very interesting substance. I've been curious about it. I have considered going to Peru and having an experience like this. I saw Anthony Bourdain do it on a food show that he did, and I'm a big fan of him, and it looked very intriguing to me. Um, so Colorado actually legalized DMT. They've legalized ibogaine, which is another treatment. Ibogaine comes from an African tree, like a nut or seeds from the tree, I believe, bark maybe, something like that. Um, and it's being looked at for use in like opioid addiction. Apparently, you can get a couple of sessions of this ibogaine. People are going to Mexico and Brazil and getting these treatments. So Colorado legalized ibogaine, and mescaline. So mescaline, that is peyote. That's the cactus. Um, I think it's a fungus, uh, like kind of like a mushroom that grows on the cactus, maybe the prickly pear cactus. I think actually, I think it's a different type of cactus, and that the Native Americans, such as the Navajo, have been allowed to use, whereas none of the rest of us are allowed to use. Well, Colorado, you can now use mescaline. So psilocybin, it's growing in popularity, and this is one of the psychedelic substances that is being researched for this psychedelic assisted therapy, and legal in Australia recently. Okay, so next one, LSD, right? So we've got LSD, another 5-HT2A agonist. The FDA has recently granted breakthrough status for use in generalized anxiety disorder, And there's also some research that shows that it may benefit for depression and substance abuse. So we'll see what happens with LSD. Now, the next one, NMDA, that's ecstasy, X, Molly's, whatever you want to call it. Um, this is one that when you hear about psychedelic assisted therapy, this is the one that's been getting the most um, research and the most airtime when you've been hearing about it. It's mostly been the NMDA psychedelic assisted therapy. Okay. So the FDA actually also granted breakthrough status for PTSD. Now, breakthrough status means that they're going to make it easier to approve it, but it's not approved yet. Um, it's also for PTSD, but also research has suggested benefit for social anxiety and autism, alcohol use disorder, and major depressive disorder. It was approved in Australia in 2023. So this one's also approved in Australia, psilocybin and MNDA. However, very recently, in 2024, the FDA actually have voted against approving it. So setback for MMDA, psychedelic assisted therapy, the FDA was not convinced that it was either safe enough or effective enough to approve. So I think it was like a 9-1 or 10-1 decision, something like that. It was pretty heavy shutdown on it, but I don't think it's going away. I think that those researching it are going to go back to the drawing board and make more applications for that. But this is a big thing that's out there, and a lot of people that have had it, they really swear by it, and I've heard amazing stories, but I've also heard that there's a lot of confounders. It's hard to blind trials. People know they've gotten the substances because they can tell the way they feel is not a placebo. So it's giving more placebo effect. Those that sign up for the trials are people that already want to use these substances. So there's a lot of confounders that makes it hard to tell if this is something that might be effective. I think there's probably something to this. Now, a lot of these substances, they of course weren't Schedule One at some point. NMDA actually was not made a Schedule One substance until the 1980s. I think it might have actually been like 1983 or 86. So it was recently added. NMDA actually used to be used by psychiatrists quite frequently. Um, LSD and psilocybin, maybe not as much. Psilocybin's a much older substance since it does come from these mushrooms, so I'm sure there's a history going back long time on that, which I'm not. It's not something that I'm well versed in, but I know ecstasy was actually used, and very recently in the 1980s. Recently to me because I was alive. So anything when I was alive, I consider recently. Um, it was turned into a Schedule One substance, whereas LSD and psilocybin, I think, were in the early 1970s, around the time that they were actually coming up with the scheduling system. So um, I think there's probably something here. I mean, when you think about 5-HT2A agonism, we're talking about you know increasing activity at one of the serotonin receptors. So this actually, I mentioned at the beginning that these substances are going outside the monoamine system. These actually are working within it, but they interact with it much more strongly than the medications that we presently have. All right, so let's move on to the next category. So this is something known as a sestrin modulator, and there's a med out there, NV um, 5138. So that's the drug that's currently being looked at. Um, let's talk about what this sestrin modulation um, is involved with this. So the protein kinase mammalian target of rapamycin, mTOR. Okay, and remember we've talked about mTOR before. mTOR is something that is being looked at for use for fighting depression. So the target of rapamycin mTOR forms part of a protein complex that is responsible for many functions, including cell growth and synaptogenesis. Right. So this is growing of neurons, the connections of neurons. Right. BDNF is involved in mTOR. So just making better connections in the brain. Right. Healthier connections. So researchers have actually hypothesized that several antidepressants, including S-ketamine and ketamine, increase neuronal levels of mTOR as one of the final actions in the molecular cascade to treat depression. So we already have meds that are interacting, even though they're NMDA antagonists, they're having effect on the mTOR system. Okay, so the amino acid leucine activates mTOR complex 1 or mTORC1 by binding to the upstream regulator cestrin, right? Because we're talking about cestrin modulation, right? NV5138, the drug in question, is a selective small molecule modulator of cestrin, which readily crosses the blood-brain barrier and putatively facilitates cestrin's activation of the mTORC1, ultimately providing a rapid antidepressant effect through synaptogenesis in the medial prefrontal cortex. That's a part of the brain. So many of you probably did not catch all that. So feel free to back up 15 seconds and listen to it over and over and over again. All right. Um, so in theory, NV5138 would bypass much of the molecular cascade that is currently necessary to increase brain-derived neurotrophic factor, BDNF, and ultimately activate mTORC1, hence providing a more direct path to synaptogenesis. This may result in a targeted response with less adverse effects, right? So we have other medications that interact with BDNF and mTOR, and this is a med that's also looking at kind of snaking its way through that pathway. This is, of course, not as easy to understand as a serotonin reuptake inhibitor. That's a very easy concept. It's a transporter protein on the cell wall and cell membrane, and we're blocking it, and its function is to suck serotonin back up into the cell, and we're blocking that. It's a lot easier kind of to understand. This is a little bit more complicated concept. But I think that's kind of the direction we're having to go to look. We're looking for new medications. All right. So a single dose of NV5138 in the required presence of BDNF resulted in a rapid and long-lasting antidepressant effect in rats by putatively increasing synaptogenesis in the medial prefrontal cortex. Okay, so once again, we have a medication that we've shown improvement in animal models. It's currently in phase 2 trials in humans. We'll see where it goes. If these medications get further developments in the future, we're getting to phase 3 trials, we're getting top line results, I will have episodes on those. All right, next, we're going to talk about BDNF modulators. All right, so we've mentioned BDNF. There's a medication known as Alto 100. The mechanism is not well understood. However, there's an indirect modulation of BDNF that occurs, which is enhanced by a number of things to include healthy diet, exercise, and psychotherapy. So we already know that healthy diet, exercise, and psychotherapy modulate BDNF. This is medication that's kind of trying to do what those things do in the way that they do them. All right. But we don't know exactly how it's doing it. It's been studied since 2010 for major depressive disorder, bipolar disorder, and PTSD. We've had some major depressive disorder trials. Phase 2A results in 2023 were positive, but then phase 2B results that came out last year in 2024, it did not really meet its endpoints. Wasn't really all that much better than placebo. And so it's unclear if this is going to be any more progress for this med for major depressive disorder. However, bipolar disorder phase 2B trials were started in 2024, results expected in 2026. So maybe something for bipolar disorder. We'll have to wait and see. That's Alto 100, the BDNF modulator. Now, Alto has another drug. Alto's got a lot of medications coming out. Let's see, Alto 202, that was the glutamate one, the GLU-N2B subunit containing NMDA receptor negative allosteric modulator. And now we've got Alto 100, the BDNF modulator. And now we're going to talk about Alto 203, which works through H3, that's histamine 3 receptor. So Alto's done something interesting that a lot of drug companies are doing now. I think they're using computer models to feed a bunch of data into systems, and it's basically the computer's telling you this mechanism might work to treat the illness that you want. And so it spit out, H3 antagonism or BDNF modulation or whatever, and Alto has then tried to develop a drug that does that thing that the computer model suggested might work, and then test it on animals and humans to see if it actually does work. All right, so that's how we're getting a lot of these new ideas, is that these I don't know if AI is involved, but the computer models are helping us predict. And there are medications getting approved that have have been suggested by a computer model. And so there could be we could be on the verge of an explosion of medications that are vastly better than what we have now. And in mental health, we sure as heck need it. Okay. So let's talk about Alto 203. Mechanism of action. It's an H3, that's histamine receptor 3, inverse agonist. Inverse agonist is kind of like an antagonist, but like a super antagonist. So it like antagonism blocks the receptor so that um, the molecule that would typically interact with that, in this case being histamine, can't do it. And so basically blocks histamine from causing the receptor to do anything. Now the receptor fires without the agonist, right? So it doesn't the H3 receptor doesn't need histamine to do something. It just doesn't do much. And when histamine comes along, it does a lot more. Okay, so when we block it, it just has its baseline functioning. But with an inverse agonist, right? So an agonist makes it work. Histamine is the agonist, right? But this drug is an inverse agonist, has the opposite effect. So it actually tones down even that baseline, right? So we get even less functioning than at baseline with no histamine able to interact. All right. So inverse agonist is a stronger negative on the receptor than an antagonist. Um, and I don't know if there actually is an H3 antagonist out there. It's called pitolisant. It's a stimulant that's used for narcolepsy. So we already have a med that's somewhat similar. It's not an inverse agonist, but it's an antagonist at H3. But what happens is when you inverse agonized H3, it leads to dopamine release in the reward system. So this is thought to perhaps help with depression. It's currently in phase 2 trials for major depressive disorder with anhedonia. They're specifically thinking that because of this dopamine release, that it may help with anhedonia um, and more. Top lines results are actually expected this year in 2025. But once again, phase 2, that gives us some idea, but until we have phase 3 results, we don't really know whether this is going to be able to get approved or not. But something that's out there that's being looked at on the horizon. Next, we have the melatonin 1 and 2 agonism. We have a drug called Alto 300. Now, this is one I've actually talked about before, as its other name is agomelatine. So agomelatine was actually approved in the EU in 2009 and Australia in 2010 by the company Servier, which was the one that developed it. Now, there was thoughts that we could possibly get this going in the U.S., but it didn't happen. They sold it to Novartis. Novartis gave up on it. Um, they discontinued their because the trials that they did were lackluster, and then they sold it to Alto. So now Alto's got it, and they're developing it again under Alto 300. The drug is as I mentioned, a melatonin 1 and melatonin 2 receptor agonist. Now, Rameltion rosarum kind of works that way. Melatonin kind of works that way. It's also a 5-HT2C antagonist. That's something that mirtazapine does, amongst other things. And so, under Alto, the phase 2A trials were positive, and phase 2B results are expected this year in 2025. So, I mean, this is a med that's already approved in other countries. There was an attempt to get it approved in the United States. I don't even think they asked the FDA because they didn't think that it would get approved. So, something that's available, if I've got listeners in Australia and in Europe, maybe you're familiar with this medication. I briefly mentioned it as when I was talking about 5-HT2C. But this is something that the story hasn't ended in the US for this medication. So we'll be looking for those results this year in that phase 2B trial. The next mechanism, I want to talk about the TrkB agonist. Um, I hear a lot about TrkB. TrkB, TRKB, that's a tropomyosin receptor kinase B. That's what that stands for. This is a receptor. It has several agonists. So BDNF agonizes it. Amitriptyline actually does, and drug under current exploration, LM22A4, is the drug that we're going to talk about that is an agonist at TrkB. It's produced neurogenic and neuroprotective effects in animal models. All right. And then there are also some positive allosteric modulators of TrkB. So we had the agonist, BDNF, amitriptyline, LM22A4, but we've got some positive allosteric modulators. So we've got the NMDA receptor antagonist, ketamine and hydroxynorketamine. We've got a lot of antidepressants like fluoxetine and imipramine, serotonin psychedelics such as LSD and psilocin. Sorry, not psilocybin, psilocin, which is also a mushroom, also related to psilocybin in mushrooms. So this is a receptor that we already have medications that kind of have an effect on, but perhaps we're looking to do something a little bit more targeted. Okay, so they're also looking at treating, in addition to depression, Alzheimer's disease, Parkinson's, and other neurodegenerative and psychiatric disorders. So you might hear TrkB. I hear it from time to time. There's a lot of interest on it. We've got this new drug that we'll see what happens with it. I don't even think it's in phase 1 trials yet. All I have is that it's produced neurogenic and neuroprotective effects in animal models. So we'll see where this goes. And then this is the last one that I'm going to talk about. So the kappa opioid receptor antagonist, buprenorphine. If you're familiar with buprenorphine, it's used also kind of like methadone. It's used to treat opioid addiction. It's usually mixed with naloxone, so that it can't be abused. If you shoot it up or snort it or whatever, the naloxone is a opioid antagonist, and so it's inactivated. But if it goes through the regular, oral GI system, the naloxone does not affect it that way. And that's how it's used for opioid treatment, because buprenorphine is a mu opioid receptor agonist in addition to being a kappa opioid antagonist. And it's the mu opioid partial agonist that we're looking for when we're treating opioid addiction, because we want to just partially agonize, just give a little bit so that they don't want to use the opioid, but not too much so that they, get high in things. And if they try to abuse it, we got the naloxone in there, right? Um, but it's the kappa opioid. So we've got different opioid receptors. We've got mu, delta, and kappa. I'm not sure if there's any more. Those are the three I'm most familiar with. So we're looking at its capioid opioid antagonist ability when we're looking at depression. And what they've done is they've mixed the buprenorphine with samidorphan. If samidorphan sounds familiar to anyone, it's because it was actually mixed with olanzapine to make a medication that was released a couple years ago for olanzapine being, Zyprexa, the antipsychotic. They added samidorphan to it to help with the weight gain. And I believe the branded name was Lybalvi. I believe that's it. Don't quote me. But, I'm not sure that it worked all that well, or that was all that worth it to add this to help reduce the weight gain that patients get with olanzapine. Okay, so that's why samidorphan may be a familiar name to you, because it's out there in that drug. But here we've got it combined with buprenorphine. And here we're looking at samidorphan as a mu opioid antagonist. So basically that mu opioid partial agonism that we're getting with buprenorphine, we're trying to cancel that out because we don't want that, right? Because that's for people that have an opioid addiction. If you don't take opioids, then you may get addicted to buprenorphine because it's agonizing your mu opioid receptor. So by adding the samidorphan in there, it helps to reduce the abuse potential of buprenorphine, and it isolates us to just get that kappa opioid antagonism, which was the system that we were looking for to just try and help with depression. All right. So this medication has been under development as an add-on to antidepressant in treatment-resistant depressions. However, unfortunately, it's had several failed trials and denials from the FDA, and it's not clear to me if there's going to be further exploration of this. Now, the drug is actually called ALKS 5461, if you want to look that up. All right. And if you want to keep track of that. All right. So that's the last of the drugs on the horizon that I'm going to go through. But, we've talked about several. Um, a few of these, it looks like, are already a bust. A few of them were awaiting, they're in phase 3 trials. We'll see what happens. Most of them are in phase 2 trials. And so we'll have to see what those results are and then even see if they get to go into phase 3 trials. But this is what's coming out the pike, right? So there's whatever the next antidepressant that is approved, it's likely going to be one of the ones I talked about today. And it's likely going to be something that is a different mechanism of action. Um, and if something else is coming out that I'm unaware of, like when Gepirone popped out there, Gepirone had been in the works for a while. But I think, we have enough medications that do the monoamine stuff, and, maybe we could do something that was more targeted to the right serotonin receptors, perhaps something like that. I think there was attempts to do that with vortioxetine and vilazodone that we haven't gone all that well. We need better treatments, but, in my personal opinion, I think more so than searching for new treatments for depression from a chemical standpoint, I think we need to do a better job of figuring out what depression is. I'm going to wrap it back up to what I talked about at the beginning of the episode. You know, what are the subtypes of depression? Like, can we actually differentiate a severe depressive type from a moderate or mild, other than just saying that they have more of the symptoms of depression than less? Is there something chemical? Is there a blood test we could do? Is there a brain scan we could do? Are there other kind of qualities to the history of the patient and clinical factors and physical exam findings that we might be able to do to determine who these people are? And might we want to consider giving them, treatments like lithium and things like that? That's certainly, when I talk about adjuncts, we'll talk about that as an option. It's not something that's super commonly done, but maybe it should be looked at a little bit more often, because maybe these folks are actually kind of in that manic depressive spectrum, and we should give them a treatment that works for that, like lithium, um, especially if other things are not working well for them, right? So maybe what would be helpful would be to do more research on finding out what these different type of depressions are, and maybe maybe who's going to respond to a bipolar drug like lithium, who's going to respond to the monoamine drugs, who's going to respond to diet, exercise, therapy, um, and different types of therapy and things like that. um, I don't know that we're going to come up with some miracle drug that's going to cure depression, because I think depression is something that is caused by so many factors. It's a multifactorial illness. I think it's caused by poor diets, by lack of exercise. It's caused by such a fast changing society where, we're not living lives we lived thousands of years ago or even hundreds of years ago. And as our brain had time to catch up to that, and with social media and cell phone iPhones and all these apps and things, I mean, are we really like is our brain really capable of handling all this, and how our whole society and social structure and how we communicate and interact, it's just changed so much. um, I'm not sure that a drug can really undo this sort of thing. I would say that, if depression is rising, it's not because there's a medical illness inherent in someone's brain that's increasing. I would say it's changes in our environment. It's changes in our social system, in our diet, in our the way we move around the world, the way we think, the way we act and behave. And so these are things that are going to be more responsive to psychotherapy. Okay, they're not going to necessarily be responsive to newer and newer medications. um, I wish there was a pill that could fix it all, and for some people there is. And I mean, in addition to kind of maybe trying to stratify who's got what type of depression and maybe who might be a better candidate for what treatment, another thing I think that I'd like to see a lot of research on is the placebo stuff. And like I said, I'm going to have episodes about that in the future. I'm going to go into a lot of depth on how to make drugs that we do have more effective. But I'd like to see more research about that. I'd like to see classes taught to residents about how to talk to patients in ways to enhance this placebo, how to identify patients that are going to be more responsive, how to identify things in patients that is what they are going to respond to. Are you going to be respond more to having a lot of autonomy? Are you going to respond better to having maybe less control and being told more what to do? Are you going to be respond more to feeling like a partner or relationship with the doctor? What identifying kind of like in each individual patient what it is that they respond to, that maxes out that placebo effect, and give them the med because the med is necessary to give that placebo. You're giving it through your actions, through your words, through your therapy, and through your drug. um, I'd like to see more research, really nailing down, when we talk about that there are folks practicing out there that are maxing out the placebo effect, and there are folks out there that are bottoming it out. What's the difference between these two? What is it that these folks that are getting the best placebo results, what are they doing? And how can the rest of us do it? I'm not one of them. I will be honest with you. I probably in the I'm probably somewhere in the lower half. I like to think logically and chemically. And that's how I always thought, but my mind's being more open to these other ideas, as I see how ineffective these meds for depression are, um, and that there is so much more that could be done. And it doesn't have to be a formal weekly therapy CBT type of situation. It doesn't have to be like you're a therapist. It could be something that you do when you prescribe the med in a monthly visit, in a shorter 20-30 minute encounter. There are things that you can do in those small bites that can maximize that. And there are folks out there that are maximizing it, and they know, and they're doing it. And they might not they probably don't even know. They're probably not even thinking about it. But it's just their personality. It's just who they are. And that's just they're having a great effect. So I'd like to see maybe more research on how they do what they do, and how the rest of us could could learn how to do what they do, so that we could all be these top performing placebo givers, right? I think you're going to get a lot more bang for your buck when you're looking at that kind of therapeutic angle in prescribing, and as well as finding better ways of identifying and stratifying patients of who's going to react better to what treatments. um, I think it's great that we're developing new drugs. Hopefully, they're amazing. Hopefully, they're great breakthroughs. Um, but I think these other things, and then I think a lot more emphasis on diet and exercise, like and how to get people to eat right, and how to change our food system, and how to change the way we provide government subsidies. There's so much more we could do from that standpoint as well. I'm going to have a whole series where I talk about like diet and exercise and how it affects health and mental health, and how we can, and what evidence we have, and all that sort of stuff. But there's a lot there. In fact, there are psychiatrists out there that are now calling themselves nutritional psychiatrists, who basically are like prescribing food plans to treat people's mental illness. And a lot of these folks are having very good results. And I don't know how much of that is the nutrition advice that they're giving and how much of it is they're in the top performer of the placebo class, right? Um, I don't know. And that would be something that would be interesting to study. Could someone who's maybe not great at that does the same thing, also get like better results than we do with the drugs? I don't know. There's so many things. If you're an interested student that wants to research things, there are so many things out there that you could research. I hope if you are one of those folks that I've given you some ideas of things that maybe you might look at doing in the future. So, like I said, I'd like to look at food. I'd like to look at placebo. I'd like to look at like finding a better system than the DSM to categorize these patients. Because, like I said, the treatments we have are not as great as that we'd like them to be. We've got these treatments on the horizon, and so far, they're not looking like they work that much better than placebo. Um, we don't know on all of them yet, and we'll have to wait and see. Um, well, I hope that you really, learned something about like the treatments that are coming out on the horizon, and I've given you something to think about. The next episode, what I'm going to talk about is how to pick an antidepressant. All right, so we've kind of gone over what they are, how to dose them, pluses and minuses to each of them, and I've given you kind of my various opinions on which ones I think are better or worse. I want to talk. We're going to have a whole episode on how do you pick uh, the best antidote. How do you make the best guess rather than just kind of randomly putting your hand in a hat and pulling out a piece of paper. Like a monkey picking stocks does just as well as a financial advisor. If you've ever heard of those studies, right? We want to do better than the monkey. We want to actually use our knowledge of these meds and all these qualities that we've been learning about to pick the best med we can first for the patient that's more likely to work. And so that's what I'm going to talk about next time. And I think it's going to be really informative. And maybe you're going to walk away with that thinking, all right, now I know my first, second, and third choice for each patient. And it's going to be different. It's going to be different for every patient. And that's the fun thing. That's the fun thing about psychiatry. We're not applying the same algorithm to every patient. We're evaluating them for their unique qualities. And then we're deciding what med maybe uniquely we think is more likely to help this particular patient. So I hope you will stay tuned for that episode. I want to thank you so much for tuning in today, and I will see you next time.